So I would like to inform all the co-panelists and all the viewers that I have done my LLB from Bangalore University, and I'm a gold medalist also in that same. So coming to my co-panelists, I have already introduced Dr. Prashanth, who is an associate professor, and he has done his certified course in medicine and law. Dr. Bhargavi, she is an assistant professor from Vydehi Medical College. She was my junior colleague. She has done her postgraduate diploma in medical law and ethics. And we have from the legal fraternity, we have another member here, Surya, Mr. Surya, who is an advocate at the High Court. He has done his education from the Kolkata University of Law, and he is a proactive, enthusiastic advocate from Karnataka High Court. Surya, I welcome you.
Thank you. Good to be here. And good evening to every one of you.
So I will just introduce what are we aiming at by this panel discussion. So the awareness of the medical legal aspects will make the practice safer. So if there is a low tolerance junction, traffic junction, we will be careful about not deviating. Like that only, awareness of the medical legal aspects will help us. So nowadays, we don't have the concept of Vaidyo Narayano Harihi, and doctor is considered as a service provider, and for the service we are paying. So if there is any deviation from the standard practice, we have all the right to question. That is how the patient perceives. So in order to satisfy the patient and also have a happy and professional life, it is important that we know about the medical legal aspects. So this webinar aims at addressing the medical legal basic aspects. Everything cannot be covered in one webinar. Basic aspects of, so that we can have a calm and comfortable professional life. So why are we so much bothered about the medical legal challenges? It is simply because many of the times, yes? I thought somebody is trying to speak. Can I continue?
Yes, ma'am, yes.
Okay. So the challenges in the presently in this field is many of the practicing anesthesiologists as well as students are not aware of the medical legal challenges. And the first time they get to know, maybe probably when they get a legal notice. When it suddenly happens, it will be like a stormy sea. It will upset the mood, it will upset the professional work, it will upset the family, and also further extreme steps taken also, we know about it. So how do we convert it into a starry sky? If you get a medical notice, have a knowledge about the medical legal aspect, look at the sky, take 2 to 3 deep breaths, read whole thing about what the notice says and how much you are fault or you don't have any fault. Analyze by yourself and then take the help of an advocate and talk to the seniors who have received the similar notices previously and gear up yourself to face the issue. So the legal notice does not mean that you have done a malpractice. It is just that the patient party feels something might have gone wrong, and it is the patient party only has to prove that you have gone wrong, and you have your defenses. Always a notice does not mean that you are wrong. So the adverse outcome by itself does not make treating doctor liable. If this were to be the truth, then all the deaths should have been associated with the medical malpractice suits. The adverse outcome relating to the non-compliance with the standard treatment only makes you liable. Adverse outcome per se does not make you liable. All the practicing anesthesiologists, in whatever capacity they are practicing, it bound to get a legal notice in their career. And it is all the more so if you are practicing in a corporate setup, if you are practicing individually, if you are practicing for a long hours and if you are involved with the high-risk cases. So it is a myth to think that anesthesia practice cannot be without a legal notice. Okay, so you should not think, oh, it is impossible. I am always right. I cannot get a legal notice. That is not possible. So with this introduction, let me tell you what are aiming at by this webinar. It is to familiarize with legal aspects of anesthesia practice and how to react to a notice. The legal aspects means what is the definition of negligence, what is the components of negligence, what is the cases on which the medical law is based, like Bolam and Bolito cases. All those things will be discussed briefly, and how to react when a legal notice appears, and some of the judgments of the Supreme Court, some of the judgments of the High Court, as well as the quasi-judicial bodies will be discussed in relation to anesthesia, or if it is not related to anesthesia, it will be extrapolated to anesthesia. And what steps can be adopted to improve the medical legal environment of a practicing anesthesiologist. So anesthesia as a specialty is unique in the sense it is a dependent specialty. Our existence is for sake of surgery, and it is also a supportive specialty. When these two things come into picture, we have a surgeon's overpower. So what happens? A surgeon will go to a patient and explain not only about surgery, he might have explained about the anesthesia also. That explanation may not be proper, but when you go and explain, the patient may take the surgeon's view in a better way, simply because he has more rapport with the surgeon than an anesthesiologist. This should be the institutional based rules are very, very important. Many of the corporate hospitals feel that the surgeons are giving the business, let them do whatever they want. That is where we are going wrong, is my opinion. So the communication of the documents and documentation of communications is very, very important. As anesthesiologists, we are very poor at documentation. If at all we speak up to the patient also, some of the junior is assigned the process of documentation, and the documentation is not even checked many of the times. And this can go against us when we face a malpractice suit. So coming to the diplomacy versus transparency. Suppose we have a case of fractured neck fever. Okay, it is possible that we can, ASA grade 1 patient also can have a massive embolism and die on the table. He may be ASA grade 1. But you can't go and explain to a young, healthy ASA grade 1 patient, you will die if you undergo this surgery. So how do we manage diplomacy versus transparency? Probably we can tell him, if about 10,000 to 1 lakh cases undergo, once in a way we may have an incidence of thromboembolism, which can be little deleterious. It is like telling you are going on the road, you may meet with the accident. That does not mean we should stop walking in the road. So that kind of a attitude should be developed, and transparency and diplomacy has to be hand in hand for us to go ahead with our practice. Duplication of the records and not coinciding. This is more common in ICU than in the OT. What happens is the senior person comes and writes one vitals, and the junior person again writes another vitals. Many of the times, those two records are not coinciding. And some life-saving inotropic support is asked for the patient at 5 o'clock. Nursing note says it started at 6 o'clock. That itself may be deleterious to us. So duplication of the records, not coinciding time-wise and drug-wise, is very, very important. The physician opinion or any specialist opinion has no bearing legally. What do we mean by this? The cardiologist, we refer a patient to the cardiology opinion. Cardiologist says the ejection fraction is about 30%. You can take him up for surgery with hemodynamic stability. Don't cause hypotension, don't cause hypertension. Our usage of the drugs, our technique of anesthesia, how much of hypotension it can cause, and how we can prevent it, only known to us. Just because he has given an opinion that does not mean that you go ahead with the surgery. You can always, if you feel even with that opinion, patient may not be able to tolerate the particular procedure, we can refuse to anesthetize. But if at all we anesthetize and get into some kind of the problem, we are responsible as per the Supreme Court decision, and it is not the person who gave the clearance. So with this understanding, I feel I will hand over the session to Dr. Bhargavi to explain the basic definition of medical negligence, components of medical negligence, documentation, informed consent, all these things will be explained by her. Over to you, Bhargavi.
Ma'am. Are my slides visible?
Yes.
Thank you, ma'am.
Yeah.
So now and then, we keep reading newspaper reports or mobile phone news updates that there has been an anesthesia overdose, and the anesthetist or the surgeon or sometimes the both the people are held for medical negligence. And the case goes on for n number of years. Then finally, some kind of punishment or some kind of fine is issued on them. So what exactly do we mean by medical negligence? Medical negligence, even in history, from time immemorial, has always been a very important thing. Doctors or medical men of the past have been punished. Sometimes an eye for an eye, a tooth for a tooth, or fines. Even in Manusmriti, it has been explained that medical men have been made to pay fines or further punishment depending on the severity of injury. Now, some common terminologies that we need to familiarize ourselves with. One is medical negligence. So what is medical negligence? Any improper or unskilled treatment of a patient by a medical practitioner is termed medical negligence. So it could be a nurse, physician, surgeon, pharmacist. In our case, the anesthetist. So what are the essentials of medical negligence? So here, whenever a complaint is filed for medical negligence, the defendant, that is the anesthesiologist, owed a duty of care towards the plaintiff, that is the patient. So he owed a duty of care, and if the defendant has made a breach of that duty, and the plaintiff has suffered a damage because of the breach of that duty that the anesthesiologist owed towards the patient, and he has suffered a damage because of that breach, it is considered medical negligence. So where all can the patient file a medical negligence complaint? One, he can file a criminal case against the doctor involved for gross negligence, sometimes involving loss of life. So he can go to the police and then the criminal court. And the punishment here is usually imprisonment with or without fine. The other place where he can go to is a civil court or a consumer forum, depending upon what kind of compensation and what kind of speed he wants the justice to be got. The third place that he can go to is the National Medical Commission or the State Medical Council. Here, he can ask for erasure of license to practice for the particular doctor. So this license, this erasure of license can be for n number of years, depending upon the seriousness of the negligence that the doctor has caused. The other fora that the patient can approach is through the National Human Rights Commission, Women's Commission, or the Child Rights Commission. Now, examples of medical negligence. One important example that I can think of is Dr. P. Narasimha Rao versus Gundamarappa Jayaprakash. This happened in 1990, where the patient underwent tonsillectomy, but the anesthesiologist failed to notice that there was a respiratory arrest. This further led to cardiac arrest, and the patient could not be revived. So here, Dr. Narasimha Rao was held responsible for medical negligence. Now, a pediatric surgeon who was operating on a child for hernia, it was found that at the end of surgery, the hot water bags that the anesthesiologist had placed in the popliteal fossa so that the baby can remain warm had caused third-degree burns on the patient. So here, both the anesthesiologist and surgeon were found to be negligent. So there is a thought to be pondered on here. If a case has been started by the anesthesiologist and the surgeon has not touched the patient, the anesthesiologist only is blamed. But if the negligence has happened over the case and at the end of the case something is realized, be it anesthesiologist's fault or the surgeon's fault, the anesthesiologist is held responsible. Both the surgeon and anesthesiologist are held responsible. So there has to be some kind of justice for the anesthetist, because we are not anesthetizing the patient for our sake. We are doing it so that the surgeon can do the surgery. So I think whenever there is such a case, both the anesthesiologist and surgeon need to cooperate with each other and help each other in proving their innocence. Now, duty of the anesthesiologist. According to the Code of Medical Ethics, non-maleficence is one of the most important codes. Whether we do good to the patient or not, in terms of beneficence, we should make sure that we don't do any non-maleficence or no harm. We should not cause any harm. This is also, you can say a similar maxim, primum non nocere, where the first thing is to do no harm. So it is the prerogative of the anesthetist to decide whether he should undertake the case or not, depending upon the facility and the resources available in that place, what type of anesthesia to be given to the patient, based on the particular case and the expertise that he has, and the actual administration of treatment. He can always refuse to give anesthesia for a particular case if he doesn't have the facility or the resource or the expertise. Now, a negligence by an anesthetist can be because of an act of commission or an act of omission. So what is not negligence? Suppose a patient who's undergone spinal anesthesia after 20 days presents with meningitis. So here, this meningitis cannot be attributed to spinal anesthesia. So here, it is not medical negligence. So what is medical negligence? In the case of Suresh Gupta versus government of NCT, the patient had to undergo a septoplasty. The anesthetist could not find a cuffed endotracheal tube. So an uncuffed tube was used in place of a cuffed tube. So at the end of surgery, the patient had a respiratory obstruction, which could not be managed even with tracheostomy, and the patient passed away. So when the postmortem was done, it was found that both the main bronchi were occluded with huge blood clots. So here, the medical negligence of the anesthesiologist was proved and he was prosecuted. Now, steps to prove a medical malpractice claim. So here, the burden of proving that the doctor is negligent lies totally, wholly, solely on the patient. So first, he has to prove that there was an existence of a doctor-patient relationship. So this could be proved with a case sheet or OP slip or a prescription or a PAC sheet with an informed consent, or the inpatient documents that we have provided to the patient. The patient also should prove that the doctor did not meet the said standards required as an obligation for this profession, as I've already told that he has a duty towards the patient. Now, because of this breach of duty that the doctor has performed, the patient has suffered an injury as a result of that medical negligence. Now, the patient also has to prove that he has, because of the negligence caused, some damages have happened, and the damage should be proximate to the injury. For example, if a patient has come to you for a sedation for MRI, and he gives you a clear history of repeated arrhythmias, and you fail to elicit a history of pacemaker insertion, and you give clearance and you go and you allow the patient inside the MRI room, this becomes a clear case of negligence. Suppose a patient comes to you after 10 years of you giving a spinal anesthesia to him and says that now he has a backache and that he attributes to the spinal anesthesia that you gave 10 years ago. This is not medical negligence. So the patient cannot claim a medical malpractice claim. So the burden of proof always lies on the patient, the only exception in this case being death on the table. So here the doctor has to prove himself to be non-negligent, and this holds good even if this death on table was anticipated. Over to you, ma'am.
Okay, so coming to the nutshell of the medical negligence, it is a commission or omission. Commission of something which shouldn't have been done, or omission of something which should have been done. The medical negligence per se is not something which can be practiced generally. So the medical negligence is a dictum which says that the commission or omission is the responsible for it. And it has also been clearly told by Bhargavi that it can be the three components. That is, there was a contract between the doctor and the patient, and something went wrong as per the patient, maybe as per the patient, and we may prove it to be not there, and it has resulted in damage. That damage should have a direct consequence to the commission or the act of omission. Without the direct relationship, it is not possible to court to take up the case. Surya, can you highlight something about the components of the negligence from the legal perspective?
Yes, ma'am. So basically, there is one Supreme Court case called Kusum Sharma versus Batra Hospital, which happened in around the year of 2010. So they have enlisted certain principles which the courts or the medical boards which are formed to investigate on medical negligence, they need to follow these principles. So one of these main principle is they're saying negligence is a breach of duty exercised by omission to do something which a reasonable man, guided by those considerations which ordinarily regulate the conduct of human affairs, would do, or doing something which a prudent and reasonable man would not do. So basically, a doctor who has a higher degree of care which he needs to take, and how he would react in a prudent situation is what he needs to prove. Anything beyond um, what an imprudent man would do is could constitute negligence essentially. So ingredients of negligence would be basic reasonable degree of skill and knowledge which a doctor needs to possess, and if he breaches that and if he doesn't follow that, that would instantly constitute as negligence. So as long as you have fulfilled your duty with reasonable care and whatever the skill the best you can do, you don't have to worry about it, and it doesn't constitute negligence at all. So and then it goes on and on, like say where it's standard of care required. So and then the treatment or the realm of diagnosis which you have done is within your scope. So those factors do come later, but the first factor is regarding your reasonable care. So if as long as you have undertaken reasonable care, it does not constitute medical negligence.
Surya, can you tell me how a court analyzes the three components? If some component is there, can a court reject to accept the case?
So the court, once the case comes, it gets, before its admission, court simply goes into the merits of the case. So they just go through what is happening. Has this case happened or not? They'll just do a basic check. And then once, if they do find that there is no case at all, it might be instantly dismissed. But once the patient proves that there has been some degree of negligence, the court will continue to hear the case. Then once the court admits a case, it will further get into the evidence part of it, whether the doctor has been negligent or not. And after that, they'll take a decision. But in case of consumer forum, it needs to be noted, there will be a technical member on board who's a qualified doctor. So approaching a consumer forum where there's a technical doctor who's a technical member who's a doctor would be a much better place to go to than going to a simple civil court where the member would not be a technical member and he might not have idea about the medical aspects of it.
So what is the incidence if suppose 100 complaints come to a consumer court? So how many get rejected or all are accepted? How is it? The incidence wise.
So incidence wise, a lot of things which we call a prima facie case,
Yes.
where we just look into the basic facts and then we'll get to know that it's probably because the patient wants to harass the doctors, unfortunate doctor, and then they are proceeding this thing. And so, but then a lot of cases also get admitted in the first place. Later, they might be disposed of, but admission is where it's enough to cause like a mental agony for the doctor. It causes a lot of harassment at the end of the day. But I would say in if you take 100 cases, out of which 30 of them get dismissed at the instant, where they just go through prima facie instance, but other 70 do get admitted and then they proceed towards the trial, where doctor will be called upon to hear his story basically.
Thank you.
So this is the harsh reality.
Thank you. I'll get back to you. Okay, Bhargavi, Can you explain about a Bolam case and Bolito case, the two pillars of the medical negligence?
Yes, ma'am. So Bolam case and the Bolito case, they form twin pillars of all the assessments of medical negligence. So the Bolam case happened in 1957, the Bolito case in 1997, 40 years apart. So what happened in the Bolam case? So Mr. Bolam, he was a medically, he had some kind of a mental illness for which electroconvulsive therapy was advised. And he approached the Fryan City Hospital, which was a part of the Fryan City Hospital Management Committee. And this was running this Fryan Hospital, which was a hospital for mental illness. So this hospital had employed a doctor who was to provide some kind of sedation or muscle relaxation during the ECT procedure. So the doctor did not provide any sedation or muscle relaxation or restraint, because of which the patient had a very bad fall and had an acetabular fracture. So Mr. Bolam filed a case against the particular doctor and the Fryan City Hospital Management Committee. And this came to a judge who asked a panel of experts whether they would have done the same thing in such a case. So half the number of the expert panel said that yes, they also would not have provided any kind of sedation, and the other half said that they would have provided sedation. So here the judge dismissed the case and acquitted the doctor, saying that if a doctor acts in accordance with a responsible body of medical opinion, he or she will not be negligent. So what this actually means is that the court is expecting whether this doctor would have behaved the same way as few of his peers would have, who have the same amount of knowledge and experience as him when faced with a similar situation or scenario. So the court is now excessively reliant upon the medical testimony supporting the defendant. So this means that this Bolam test is actually, so this test started to be extrapolated for all the medical negligence cases. So any doctor faced with a medical negligence claim, the court would ask for an expert panel, and if few of the expert panel members say that yes, they also would have done so, the doctor would be acquitted. What happened in the Bolito case was that a 2-year-old child, Patrick Nigel Bolito, was admitted for croup. So he had very severe cough, which each bout of cough would cause pallor and desaturation. So initially when the baby came to the OPD, the pediatric registrar who saw the baby advised some medication and set the baby. So on day 2, the baby presented again, and the pediatric registrar recognized that the baby was much sicker than the previous day, and she gave an individual nurse to monitor the baby. Now this nurse, she called the pediatric resident, who in turn called the pediatric registrar and informed that the baby is having continuous bouts of cough, and each time the bout of cough is causing severe pallor and desaturation. Neither the pediatric resident nor the pediatric registrar turned up, and ultimately with the 4th bout of cough, the baby passed away with cardiac arrest. So now when this case came to the court, the judge again, like the Bolam test, he formed an expert panel with 10 people. So out of the 10 people, 7 of them said that they would have come and intubated the patient, and probably that could have saved the baby. And the remaining 3 of them said that no, they would have given other supportive measures. Since the baby's reflexes were good, he was coughing, they would have probably done something else to reduce the cough of the baby, and they would have given supportive measures. So here, when the doctors were asked what they would have done, they said that even if they had come, they would not have intubated the baby. So now whether to take Bolam test into consideration in this case was query, because the court could not decide, because the doctors did not even turn up to see the patient. So at this point, it became the responsibility of the court to determine whether or not that particular course of action that the doctor has taken was logical or not. So here the responsibility lies on the court, where a more inquiring stance is taken to test the medical evidence offered by both the parties in litigation, and the court reaches its own conclusions instead of totally relying on one of the expert panels. So ultimately, we can see that in the 40 years from Bolam to Bolito case, there is a paradigm shift in the way the court looks at a medical negligence case. So now it is more of a responsibility of the doctor to behave more responsibly towards patient care. So the first case where Bolam test was used in India in 1967 was Lakshman Balakrishna Joshi versus Dr. Trimbak Bapu Godbole. Here, the Dr. Trimbak Bapu Godbole reduced a fractured femur by giving only morphine and a little hyoscine. And then after setting the fracture with a spica, POP spica, the doctor handed over the instructions to his junior and went home. In the next 2 hours, the patient developed severe breathlessness and passed away. So whether the doctor was responsible or not in leaving the patient who he had sedated with morphine and hyoscine and who had just been treated for the fracture of the femur was correct or not was dealt with by the Supreme Court using the Bolam case, and the doctor was found responsible for medical negligence and he was penalized. So the standard of care that the court expects is not to be of the highest degree or the lowest degree. It is expecting reasonable degree of skill to be shown by the doctor, similar to his peers who have similar medical experience and similar qualifications when faced with a similar circumstance. Over to you, ma'am.
Okay. So what I would like to highlight here is Bolam case happened in 1957 when the anesthesia was not so advanced. They were scared to give anesthesia for ECT for the fear of losing the patients because of anesthesia. That is one thing I want to highlight. Second thing is, in 1957, there was no concept of informed consent. And we have to appreciate the judge who took so much of effort, analyzed and gave a judgment. Now coming to the comparison between the Bolam test and Bolito test, in both the tests, in both the cases, we have two opinions. In the first one, to give anesthesia for ECT or not. In the second one, should we have intubated or not? So in the second one, the claim was if we were to intubate also, if we were to attend the case also, we wouldn't have intubated. When reflexes are not, reflexes are fine, we tend not to intubate. But the court said you are not attending the case and claiming that if I were to have come also, I wouldn't have intubated cannot be a safeguard. So they found them to be negligent. It was not attending the case which was pointed out in the Bolito test. So that thus Bolam and Bolito tests are applicable in many cases, and some of the judgments go beyond these tests and different principles are applied, and which are time to time which are applied in the Supreme Courts are becoming law, which we call it as precedents. Surya, do you have anything to add?
So the latest precedent, as ma'am, I would like to put it here. Supreme Court recently, there's this one case of nasotracheal intubation.
Yes.
NI is what it's called.
Yeah.
So there was a debate on that. So Supreme Court essentially held to hold a medical practitioner liable for negligence. So a higher threshold limit must be met. So it's say now we have evolved from Bolam Bolito test.
Yes.
And that's what shows how, depending on the advancements, as ma'am said, 1957 anesthesia advancements were a little less. So as and when Supreme Courts keep going on and then putting an inquiry and then evolving the law. So the law gets evolved over time. And the latest thing is this, what they've said is higher threshold to protect the doctors from medical false suits of medical negligence. So they have evolved a higher threshold than what it was earlier.
I have gone through this case. Let me explain this case. It's a very interesting case. A patient came with a polytrauma to the extent that immediately tracheostomy was required. Following tracheostomy, in order to wean the tracheostomy, when they removed the tracheostomy tube, the breathing was inadequate. So they put a nasotracheal tube. So maintenance of is easy and oral hygiene also can be maintained. And later, when the nasotracheal tube was removed, patient had aspiration. It was because of the false passage. The allegation was the false passage happened because of the nasotracheal intubation. But whereas the patient forgets that when she came immediately with so much of polytrauma, immediately tracheostomy was done. And tracheostomy is always associated with long-standing tracheostomy is associated with a false passage. So the court has perceived it and said that this cannot be considered as negligent. So it's a beautiful judgment, and it says that for each and every small thing, if the doctors are penalized, then they will take a defensive stand, and they may not agree to treat the high risk cases. So it becomes a socially obligation that we cater the doctors in a proper way, not to penalize for small and petty things, which are consequences of the treatment.
And just to add something here, I'll give you a timeline of how this case went. So the incident of the case happened in 2004, and then there was a consumer forum judgment in 2018, where 14 years was spent in litigation, and then appeal to the High Court and the Supreme Court, and finally the doctors who were penalized earlier in 2018 got got a judgment in their favor in 2023. So almost 19 years is what the harassment they went through, or the mental agony. So that is, you cannot give any relief for that. So to avoid any such situation is all these whatever the ma'am is saying regarding how they need to keep up, or like say what is going to come up in anesthesia and how they need to maintain the practice. I think that is very, very crucial to keep in mind.
Thank you. Bhargavi, can you highlight about the informed consent and its importance in anesthesia?
Yes, ma'am. So a medical practitioner cannot examine, treat, or operate upon a patient without the patient's consent, except by committing a trespass or assault. So this has been reinforced by the Consumer Protection Act of 1986 and the National Medical Commission, which make it mandatory to take an informed written consent before even touching the patient. So what is this informed written consent? It is a legal terminology where the patient is giving us an autonomous informed authorization to the doctor, or it could be for a medical or a surgical treatment, after proper discussion between the doctor and the patient, where all the relevant aspects regarding the procedure to be done or the treatment to be given, the pros and cons of the procedure, and the pros and cons of any alternative procedure involved, if available. So there are some parts for the informed consent. One is complete disclosure. So we have to be totally transparent when it comes to disclosure regarding a particular treatment or a particular procedure. So as Madam already mentioned, this is a very dicey situation where we have to balance transparency versus diplomacy. So we have to disclose the pros and cons of the procedure, especially the cons of the procedure. And while disclosing, we can always mention what percentage of complications can occur with a particular procedure. So in a case where Dr. A.K. Mittal versus Rajkumar in 2009, what happened was a child, a 9-year-old child, was operated for modified radical mastoidectomy. So the consent was given by the father, where the doctor told that it's a simple procedure and the child would be all right after the procedure. So details of the procedure nor the side effects of the procedure were not informed. So risk of facial palsy was not explained, and post-procedure facial palsy happened and this was permanent. So the father went to the court. Here the doctor was held liable for medical negligence. Next is comprehension. We need to make sure, take all our possible, we need to do our level best to make sure that the patient or the patient party comprehends what we are saying about the procedure. So in case he is unable to comprehend, there are a lot of latest technology available. We have Google Translate, we have interpreters. We can make use of all that. Suppose the patient or the patient party is specially abled, suppose he's blind, deaf or dumb, we need to use adequate measures to make sure that they comprehend whatever we are telling properly. Next is absence of any outside control. The patient and the patient party should be signing the informed consent sheet out of their own free will without any coercion. They should be competent to sign, that is, they should be at least 18 years of age. They should not be under the influence of drug, alcohol or anesthesia. They should also be mentally sound. So the actual consent sheet should be in writing with the signature of the patient attender, that is the witness and the anesthetist. Date and time should be mentioned, and all three, it is better to sign at the same time. If the patient is unable to sign or the witness is unable to sign, their left thumbprint can be taken. Now, there are two cases which I like to highlight. One is Arjun Balakrishnan Iyer versus Sony Hospital. Here, the consent had been taken only for ovarian cystectomy, but during the procedure, the uterus started to bleed profusely, and as a measure to save the patient's life, the obstetrician came out, took the consent of the husband, and went ahead with doing a hysterectomy. But when the patient woke up, she was not okay with having a hysterectomy done under anesthesia without her consent. So she filed a court case, but the doctor here was acquitted because he was doing this procedure as a continuation of the ovarian cystectomy only to protect the life of the patient. So he could not close and then wake up the patient and then come back and do a next sitting. Otherwise, she would have bled to death. In a similar case involving Samira Kohli, a 42-year-old unmarried female, and Dr. Prabha Manchanda, Dr. Prabha Manchanda went ahead with a diagnostic laparoscopy because Samira Kohli had come with menorrhagia. And when she went in, she saw that the patient had a frozen pelvis. Now, there were two options. She could come out or she could go ahead with a hysterectomy. She went out, took the consent of the patient's mother, and went ahead with a hysterectomy and salpingo-oophorectomy. The patient woke up, was unhappy with the decision taken, and filed a case. Here, the doctor was held medico-legally negligent because this was not a life-saving procedure. We could have woken up the patient and done the procedure in a second sitting. But Dr. Prabha Manchanda said that most of the she did that because she could save a second sitting for the surgery and save another exposure to anesthesia. But this was not taken and she was held responsible. The second case is Shailesh Shah versus Afrem Jayanand Rathod, where there was no consent taken for a second surgery post-laparotomy when the patient developed a fecal fistula. So what is our role as anesthesiologists when the surgeon decides to go ahead with a second surgery or wants to continue a surgery when it's not emergency? So our role as anesthesiologists is that we should warn the surgeon that in case it is not an emergency surgery, let's stop the procedure here, take a consent for the second sitting, and she can be anesthetized or and operated at a later date. If it is a emergency, the patient still can, the doctor can go ahead with the surgery. So what is substitute consent? Substitute consent is when consent is given on behalf of a patient who is not competent. Usually, this is medically valid only if we need to give consent to save the life of the patient. So the medical superintendent of the hospital or the unit head or the surgeon in charge can give a substitute consent or proxy consent. Sometimes when the doctors are admitted to the hospital, at the entrance itself, there is a blanket consent taken that any untoward occurrences in this hospital, the doctors, nurses, and other paramedics are not responsible. So such blanket consent taken by especially corporate hospitals is legally invalid. Withdrawal of consent. Now, consent is a willful act. So there is no coercion involved here. So in case the patient at any time feels that she does not trust the doctor or is not comfortable with the procedure being done, she can always withdraw consent. So we are nobody to force her into getting the procedure done or getting treated under us. Refusal to give consent. So this refusal can be explained with a case involving Dr. T.T. Thomas versus Srimati Eliza. So this happened in 1986, where Mrs. Eliza's husband had come with a perforated appendix to the Dr. T.T. Thomas in government hospital in Kerala, where he was the civil surgeon. So he examined the patient and immediately said that a surgery is required. The patient and the patient party refused to give consent. So the doctor waited for the consent for 2 days. At the end of 2 days, when the patient had deteriorated significantly, at that time consent was given and the doctor operated him. Despite his best medical efforts, the patient passed away and then a case was filed. Here, Dr. T.T. Thomas argued that he was waiting for a consent because taking consent is very important. Yes, taking consent is very important, but documentation of that consent is also important. Unfortunately, the doctor had not documented the consent or the refusal to give consent. So he was held liable. So documentation with patient and witness's signature with date and time and the surgeon and anesthesiologist signature is required in case the patient gives a negative consent for any procedure. Over to you, ma'am.
Okay. So as far as consent is concerned, I would like to highlight 2-3 things. There were days, oh, you have come for a hernia surgery. I have done the appendicectomy also. The doctor was appreciated very much. Those days have gone. So whatever consent you have taken, do only that part of it. Don't extend thinking that you are doing a very great job. That is one thing. And when a patient refuses for a life-saving procedure consent, please document the refusal also. That will be saving you when they file a case. And the consent at 18 years and plus, sound mind is what is requested. Many of the times we get patients in an unconscious status without any relatives, and we may need to do some life-saving procedures. That is when the consent of medical superintendent is taken. It is not taken in a conscious patient. It is unconscious patient without any relatives. Only such time the medical superintendent or anybody in charge in the hospital can give, which we call it as a proxy consent. So the positive aspect of the consent and refuse to give consent, both has to be documented with evolution of electronic medical records. So it is very, very important, and they become self-evident. So nothing written will be there. It is stored. So it becomes self-evident. We have to be more careful regarding documentation and the consent. Surya, would you like to add anything or any case law which you can remember?
Yes, ma'am. So I would like to add one thing. As ma'am has already pointed out, documenting evidence is one thing, and for legal procedural point of view, keeping of records for minimum 3 years is very, very crucial, because the patient might come for a claim not immediately. They might come after a year or so. So at least for 3 years, that keeping of records is very important. And also I would like to...
period are you talking about, Surya?
Yes, ma'am. That's why I would, legal procedural point of view, I would always suggest anyone to keep those records at least for 3 years.
Okay, and it varies for the different processes, birth, death and all those things. Does it vary?
Death and all. It varies based on circumstance. But if we can take a quick this thing as 3 years, that should suffice. And in the electronic age, I think we can afford to keep it forever.
Yeah.
Because that's something we can do. And also, I would like to point out one thing. There is Indian Medical Council Professional Conduct, Etiquette and Ethics Regulation in 2002.
Yes.
So that also mandates specifically of document keeping for 3 years. And then it also suggests that the doctor, whoever so treating, should also keep an electronic version of the same documents. So okay, abiding by these regulations should be very crucial for the procedural point of view.
So here I would like to request ICA and ISA, if a surgeon wants to continue with the surgery, of course we cannot wake up the patient. So what should be our stand as anesthesiologist? Though Bhargavi explained very beautifully, but it does not happen actually in the fact. That's whenever we are doing a surgery, we all know that surgeon rules and the corporate hospital support him. There should be some rule when he wants to continue with the surgery for which the consent has been taken. What is the role of anesthesiologist? At least can we take it as a defense in the court of law? For that, what documentation has to be done? I request ICA and ISA to take a call on this. This is my request. Okay, continuing with the panel discussion. Bhargavi, can you highlight on documentation?
Yes. So, importance of record keeping and documentation. When Emperor Titus addressed the Roman Senate around 80 AD, he said verba volant scripta manent, which means that spoken words fly away and written words remain. So documentation is the best defense any doctor can have. This shows that there was a proper continuity in care, and it enhances that there was a communication in an interdisciplinary healthcare team. ISA has issued guidelines on how to maintain good anesthesia records. I think all of us should go through these guidelines. So, but the problem with documentation is there can be collateral damage because of this. So always tally the documentation between superiors and subordinates. Interdepartmental references should have similar details, timings, and dates. Nurses and other paramedics' notes should tally with our notes in terms of drugs, dosages, and timings. Over to you.
Okay, so the documentation is a very important part of it, and many of the times well executed perioperative care the fails to be a defense because of lack of the documentation. See, the documentation means even the anesthesia procedure. So if you write spinal anesthesia was given at L23 and so much and so drug was given, and if you have not mentioned that it was painted and draped, aseptic precaution was taken, and suppose the patient develops meningitis, it will be attributed to the negligence. And your endotracheal tube was put, you have not written at what level it was fixed, all those things, and how the placement of the tube was confirmed, EtCO2 tracing was there. All these things are very, very important. So documentation becomes a very important thing, not only intraoperative, pre-operative, as well as the post-operative documentation is very, very important.
I would like to add one thing here.
Yeah.
Because I would say the coordination between all the departments is very, very crucial. Because if there's any, as ma'am said earlier, mismatch among these documents, so that is going to create a doubt in the mind of a judge who's going to sit on this case. Oh, why is there a mismatch? This will need my attention, and then he'll go on to admit the case. The doctor might be acquitted later, but these sort of small. The suffering is again endless.
So it is very, very difficult to adjust between the department. Interdepartmental problems only we have experienced, we will know it is very difficult to get a same this thing and all those things. Anyway, that is a practical issue. Let us not go into that. So let us go ahead with some of the closed claims and what principles of the medical legal principles have been explained in those cases. Dr. Prashanth?
Yes, ma'am. I'm just sharing my screen.
Yeah.
So my screen is visible?
Yes.
Yeah. So I'll be speaking about the anesthesiology related closed claims. So important to note here is important Supreme Court and High Court claims related to the medical world. So any judgment passed by the Supreme Court becomes a law by itself. So the first case which I want to discuss is the medical profession and the criminal law. It's the famous Jacob Matthew and state of Punjab.
Not heard, Prashanth.
Okay. Ma'am, now am I audible?
Now you are audible. Yes.
Yeah. So it is the medical profession and the criminal law. The Jacob Matthew and the state of Punjab. Here, the patient was declared dead in February 1995 and the judgment was given in August 2005, a decade. So Mr. X, suffering from end-stage cancer, was admitted in hospital. Consultant refused admission as no more treatment was possible, but was admitted due to political pressure. Later, the patient complains of difficulty in breathing, and according to the patient's view, no doctor attended for 20 to 25 minutes, which we should note that sometimes the doctor might take some time in attending going to the ward. Later, it was documented that oxygen cylinder was found empty and no arrangement was made to make the oxygen cylinder functional. And later, the patient was declared dead after 7 minutes. So the deceased son registered case under section 304A IPC. So what is the section 304A IPC is, whoever causes death of person by rash or negligent act shall be punished up to 2 years or fine or both. But the judge noted that unavailability of equipment or drugs cannot be held as criminal negligence of doctors. In the same case, the Supreme Court also gave guidelines regarding how to prosecute the doctors with criminal law. The complainant has to produce prima facie evidence in form of credible opinion from another competent doctor to support charge of rashness or negligence. The investigating officer should obtain independent and competent medical opinion and doctors should not be arrested in routine manner. Over to you, ma'am.
So the criminal law which comes into picture in the medical negligence is 304A, which is highlighted by Dr. Prashanth, 317 and 318, which are simple injury and grievous injury. See, but there are two cases. One is Jacob Matthew case, where the patient was going to die. Everybody knew about it and they refused the admission. Nothing more is there for the treatment and you keep it at home. If he were to be kept at home also, he would have died. Okay, such a patient complains criminal negligence, which is 304A, that to 304A. The problem here is when they have the political pressure, we get into such kinds of the problems. And now the Supreme Court has clearly said that if you want to investigate under the criminal procedure, there should be an investigation officer who is called as IO. He should come and take over the records as well as the body, and body has to be subjected to the post-mortem. And with all this, the doctor should not be arrested. If at all there is a scare that the doctor is going to run away, only then the arrest should happen. Otherwise, as already I have told, it is very difficult for doctors to take up high intensity cases. So it is very difficult for society to get the services of the doctors. So going ahead with the other case laws in closed claims, I request Prashanth to go ahead with the other cases.
So the other case I want to speak about here is the one of the costliest claim which was put in the Supreme Court. It was by Dr. Balram Prasad versus Dr. Kunal Saha. A compensation of 6.08 crore with interest from date of complaint. Here the couple, Dr. Kunal Saha and Mrs. Anuradha, were from USA. They were in Calcutta when visiting India, and Mrs. Anuradha, she developed fever and rash when in Kolkata. She approached a physician who suggested dopamidol injection. On dopamidol injection, the condition deteriorated. She was admitted to Hospital A on 11th May 98 in Kolkata. As her condition didn't improve, she was later shifted to Mumbai, and she breathed her last in Mumbai on 28th May 98 in Mumbai. The death was on May 98 and the judgment was in October 2013. The complainant claimed damages for loss of future earnings, loss of US Social Security income, treatment charges, other charges, court and advocate charges, and emotional distress. The court, after hearing this, has awarded compensation of loss of income of 5.72 crores, cost of medical equipment 7 lakhs, travel and hotel expenses 6.5 lakhs, litigation cost 11.5 lakhs, pain and suffering of deceased 10 lakhs, totaling up to 6.08 crores plus 6% per annum interest for 15 years. Nearly 11 crores has been awarded to the complainant. Over to you, ma'am.
Okay, this case has a really funny way of calculating the compensation. See, for a person who earns more, the hospital doesn't charge more. Then what is the logic in deciding the compensation based on a person's earning? His longevity is calculated on an average. If the patient might have died because of some other accident immediately also. So, and not only that, an anesthesiologist in his lifetime, by practicing day in, day out also, it is not possible to earn that many 11 crores or not even 1 crore. And the compensation should be proportional to the hospital charges and the consultant charges. So this, regarding this also, we should approach the authorities, and I request ISA and ICA again for this approach. The second thing I would like to quote is from all the cases so far discussed, we have seen that it takes a decade or 2 decades like that to get a judgment. So in 95 of 100 medical negligence claims, majority of the times out of court settlements are chosen. So this out of court settlement, can you highlight about that, Surya?
Yes, ma'am. So once the case goes to a civil court, there's this something called compromise petition. Say you and the patient, say a doctor and a patient, they can outside of the court, they can settle. Like say if the patient has demanded say 1 crore, you outside of the court, you can always convince the patient, say if you go ahead with the court procedure, it might take around 5-6 years, but we will settle it among ourselves to a certain amount, X amount. So this process is called mediation. So, but the case, once it goes to a consumer forum, it cannot go to mediation at all or arbitration. It has to be decided by the requisite consumer forum. So
Why
that's
is
going
it
to be
so, Surya?
so the consumer forum essentially is built for speedy disposal of justice. So
Okay.
since they say that we are only giving you a judgment speedily, and then
Okay.
to benefit the patient, why go approach a different forum? But in case of a civil court, you can always have this option to go for either arbitration or mediation or negotiation with the client. And once your court is set, once the settlement is done, you can file a compromise petition and the case will be withdrawn. So this will help in reducing the duration of the case. But it's going to be still cost to the, it will only save the legal expenses. But at the end of the day, yes, ma'am.
Mediation and arbitration, it can happen when the case goes to civil court only, is it?
Civil court only.
Okay. The contract and tort-based claims.
Claims where if the patient has approached a civil court, and then only there can be an option for arbitration, mediation, and other things. But once it goes to a national consumer forum, there can be something called an out of court settlement, where you can convince the patient who has filed a case against you, and if he wishes to withdraw, quoting out of court settlement, that can be done. But court cannot direct, oh, go for mediation, go for arbitration.
Okay, so when out of court settlement, does it have the court's authority? Like he can again claim no, that again he can come back and I was forced to sign, that is why I signed.
So that is what crucial is, the compromise petition which is going to be filed at the court. So
Okay.
the patient has to, again, as the consent form when he fills, he needs to ensure that he was not coerced, he was
Okay.
not whatever. After that he signs, and court will also ask him in the presence.
Okay, they have to attend the court to authenticate this.
Authenticate the compromise petition.
What is the approx duration of these things, Surya?
From my experience, minimum once the court is a case goes to the court and it gets admitted and hearing, everything happens, minimum on this thing will take 4 to 5 years, even if the doctor has not done anything at all.
Yeah, okay. So, and what you want to say about the compensation part?
So the compensation part, what they have adopted is, in case of death, they adopt this thing called multiplier method. Say they will calculate your age and how many years of service left, and they'll multiply what is your annual income and add another 30% for inflation. That was what was followed earlier. But now, since it has been evolved, so now they are not considering only that. On top of this, they're also ordering insurance claims, how much insurance he had and how much he would have got had he claimed that. And then they are adding mental agony cost for the patient. And then they are adding things like, say, future medical expense. Say a person has gotten some other illness because of this medical negligence. So he has to treat that. So there it becomes very, very arbitrary and depends from case to case. And then as the previous panelist just said, this one case where it was 11 crores, it is sometimes it can be justified. And but as ma'am said, like say hospital
no, it should be proportional to the then we should be allowed to charge more for a rich patient, no?
Definitely, but that's the harsh reality.
Okay. So, let us continue. You have more cases, Prashanth? Yeah. So the principle of res ipsa loquitur. Okay.
Yes, ma'am. So I'll be speaking about res ipsa loquitur, where the thing speaks for itself. mere occurrence of some types of accident is sufficient to imply negligence. There are 4 elements for res ipsa loquitur. That means there's a duty of care of the doctor, and there should be breach of duty. That means the doctor failed to provide this care. Causation, this caused injury to the victim, and damages. And as the damages happen, the victim is injured. Sorry. So I want to discuss a case about Achyutarao Hariban Kodwa versus State of Maharashtra, where the death of patient happened and the suit was filed by husband and children. The death of patient was in July 1963 and the judgment was in February 1996. Here the patient had underwent 2 surgeries. At the end of first surgery, a mop was left inside the abdomen, and this mop led to infection, which led to the second surgery, and the patient was not able to, they were not able to save the patient because of the infection. Hence, res ipsa loquitur was applied, and the doctor was found to be negligent. So, any wrong leg operated, wrong eye operated, also it comes under the res ipsa loquitur. Over to you, ma'am.
So res ipsa loquitur is the principle. There is no need for the patient to prove at all. If something is left, that itself is the proof. But in anesthesiology, we should remember when ASA grade 1 patient comes out with hypoxia or death, many of the times the res ipsa loquitur is applied. When res ipsa loquitur is applied, it becomes the duty of the doctor to prove that it is not true. The hypoxia could have happened due to the inevitable circumstances. As I always tell, many of the anesthetic drugs, it is not possible to give the test doses. And when we use that drug for the first time, it is possible they can have a severe reaction and thereby the hypoxia, bronchospasm-induced hypoxia can happen. So it becomes our duty. So it is very important that res ipsa loquitur is not applied everywhere. What is happening? Okay. Can you explain about vicarious liability?
Yes, ma'am. So vicarious liability is the liability of an employer for negligent act of its employees. An employer is responsible not only for his own acts of commission and omission, but also for the negligence of its employees. Example, if senior anesthesiologist delegates his task to his junior, then for their wrongdoings, the senior anesthesiologist is responsible. Hospital may be held directly responsible for faulty premises, equipment, inadequate or unqualified staff. It is liable for injury to patient by negligence from surgeon, anesthesiologist or members of the hospital. The exception are consultants. Even a small nursing home doing surgeries, it is important to have a ventilator backup for unexpected ventilatory care. So what is the relationship between the surgeon, the anesthesiologist and vicarious liability? In surgical cases, usually the contract is between the surgeon and patient. Anesthesiologist has implied contract with surgeon. That means the surgeon is vicariously liable for even anesthesiologist's mistake. Hence, always separate consent for anesthesia is always more sound and valid. So what is the anesthesiologist involvement in this vicarious liability? Choice of anesthetic is anesthesiologist's choice, and surgeon should not and cannot commit him to a specific anesthetic approach. If anesthesiologist administers an improper anesthetic at surgeon's instance, it is he who is liable, not the surgeon. Example being the Spring Meadows Hospital and other versus Harjol Alwal, where for a child, an adult dose of typhoid injection was given by the nurse. For this, the hospital and the doctor were held vicariously liable for this case. Over to you, ma'am.
So the vicarious liability is like master-slave as well as employer and employee. For the mistake of the employee, employer is responsible. But it should be remembered that it is applicable only in the civil law and it is not applicable in the criminal law. So the vicarious liability is the one which makes the corporate hospitals employ specialists as consultants. When you are a consultant, you are liable for your negligence and the hospital is not liable. Hospital also is sued. They will take care of the hospital compensation and they are not responsible for the compensation which you have to pay. So, Surya, anything you want to add?
Yes, ma'am. So I would like to add one thing. Hospital is also implicated as a party in most of the civil cases.
Yes.
With keeping in mind the reality, I would like to say, with keeping in mind for a higher compensation. That's all.
Yes.
So to extract more from the hospital and as well as the doctor, this is done. So even as consultants, sometimes they allow for hospitals also being implicated as a party. So even hospitals suffer in those cases. And also there's something called joint liability. Sometimes both the hospital and the employer and the employee both are liable. They're jointly liable for this thing. So in that case, it'll be 50-50.
No, if it is employee, the
Huh?
employee has to pay, is it? No.
Employee, that's what is joint liability. It depends on how the contract is between the employer and the employee.
Okay, so there can be that kind of
a contract, that's the hospital administration and the doctor.
And also, can you highlight something about the hospital having a advocate for themselves?
Yes, I think it's very, very crucial to for hospitals to have an advocate for themselves, because every contract they sign needs to be legally sound, including a small vendor contract also. Like say they have a contract with a canteen. What kind of food is to be served? Say in case the patient admits himself to a hospital and then he gets sick eating that food.
Okay,
so,
that also can be a claim.
That also can be a claim. So to keep in view of the future claims which might come, so every contract which a hospital will have should be vetted by a legal professional. So that becomes...
That advocate who is employed by the hospital, will he be able to help a consultant also?
I don't think he will be able to help a consultant.
So consultant has to employ his own advocate.
His own advocate. Maybe if they have a good understanding, it could be helpful. But in general, from what I have seen, the hospitals has its own advocate. The doctor has its own advocate.
Okay. So I have few more things to highlight. We have to know about the Consumer Protection Act. Though it was enacted in 1986, the services were included in 1995 or 1996, from when the medical profession was included in the Consumer Protection Act. So there is a modification in 2019 also. And Dr. Prashanth, can you highlight about the Consumer Protection Act?
Yes, ma'am. So in Consumer Protection Act, though it was introduced in 1986, the doctors were included by an important decision by the Supreme Court made in November 1995. As earlier told, any decision made by the Supreme Court becomes a law by itself. So it was Indian Medical Association versus VP Shanta in November 1995, where it told that medical practitioner is regarded to render service, and people availing such service are consumers and will be tried under Consumer Protection Act. So who is not under this Consumer Protection Act? A doctor renders service free of charge to every patient. Is not rendered on CPA. A doctor is under a contract of personal service. So any government doctor or a private doctor, though if he's not charging any patient, but he's paid salary, so even he'll be liable under the Consumer Protection Act. Over to you, ma'am.
So the Consumer Protection Act just says the doctor is getting paid, whether by the patient or any other authority, comes into the Consumer Protection Act. If the doctor is not claiming any fee, then he will not come into the Consumer Protection Act. Even then, the negligence can be claimed through the civil court, and it can also go to the KMC, NMC, other courts. So this is about the Consumer Protection Act. In 2019, we were all very excited telling that the term was removed from the thing. So, but actually it is not so. If you go to the Consumer Protection Act and see the definition of the service, it gives a lot of definition and it does not end here. That is what it says. So we are still under the Consumer Protection Act only. Nobody should think that our services are no more included in the Consumer Protection Act. So, Prashanth, anything else you have to say?
No, ma'am.
Okay, there were 3 questions which was flashed. So I don't know whether we should answer that, and I have few more slides. Can we go ahead with that? Who will take the call? Sir? Radhakrishna, sir?
You can finish your slides and then take up the question.
Okay, sir. Okay. Okay. Somebody is calling.
Radhakrishna here, Sunitha.
Yes, sir. Yes, sir. Hello? Hello?
Ma'am, this is Dr. Vineet from Malleswaram Hospital. You may proceed with your slides and then take up the question.
Okay, sir. Okay. Okay. Here I have to, can all of you see my slides? Hello?
No, ma'am, not yet,
No,
ma'am. No, ma'am.
not visible.
No, I think I have not shared it, I think. 1 minute. Sorry. Okay. Now? Now?
Not yet, not yet.
Not it. Yeah, now?
Yes, ma'am. Now we can see, ma'am.
Okay, so this is one thing I want to highlight. Suppose I am accused with the medical negligence, I can take an affidavit from one of my senior colleague who has more experience as to whether what I have done is medically right or wrong. And this affidavit itself may save us from the negligence, the accusation of negligence. And if the affidavit is not satisfactory, court can ask the expert from whom I have taken the affidavit to be present in the court, and he may be cross-examined also. If all these things are not satisfied to the court may appoint an expert. So this, few of the anesthesiologists who had a case, one case wherein the spinal anesthesia was given and later patient developed meningitis, and in other hospital it was written as iatrogenic. The patient went to the court saying that the doctors themselves have said it is iatrogenic, so I have to get a compensation. So at that time it was proved that all the procedure, the very nice documentation under strict aseptic precaution, this was done, that much only can be done by an anesthesiologist. It was written and the affidavit was given by me, and he was acquitted of the medical negligence. This is one beautiful provision, especially in the consumer court. It will reduce the time frame also. So what to do when a legal notice arises? Not to panic, not to announce to the multiple people, because each one has their own opinion. You will be not knowing what to do about it. Study the notice, understand the problem, and need be take assistance of an advocate. Collect the case file, note down the events chronological order, and facilitate the para-wise reply to the notice. We have to reply in a para-wise. Go through the literature and be ready to submit the copies of the court which will support you and say that you are not negligent. Surya, anything you want to add here?
Yes, ma'am. Crucially, you have to take advocate's assistance. Just like, say, if I fall sick, I would first go to a general physician who would then refer me to a specialist based on the circumstances. So even here in this case, once you receive a legal notice, anyone can receive a legal notice. You have to first stay calm, and then later first thing is, as ma'am has said, analyze your case. Has the person made a genuine claim or a non-genuine claim? Do your due diligence also. But the reply to that legal notice ideally has to be done by an advocate. So any advocate who you can approach or who you know in your circles, once you approach them, they'll know in their circles whom to guide you to. Just like, say, if I fall sick, I can go to a general physician, and doctors likewise have their own network who will put me to whichever department I need to go to. So I think it's crucial that you need to reply to that notice, and then you will need assistance legally in this regard.
Surya, I just want you to tell me, I had few doctors who approached me with the notice, but that notice had not come from the court. So it had come from the lawyer's office. So
Correct.
what is the validity of it and how to go about it?
So the lawyer's notice is essentially a threat before they go to a court or the consumer forum. So what they would claim in that notice is, so and so, you doctor has committed a medical negligence and I have suffered damage because of that. So before I go to the court, I would want to settle it with you. If you give me so much money, that I will not go to the court. So you don't need to panic in that regard. So legal notice is essentially a threat that that person will go to the court later.
No, should I reply or not?
You can definitely, I think the reply has to be given to a legal notice.
Okay.
Sometimes if you feel that it's a non-genuine claim,
Yes.
It has come from a very, very false source, I don't think you have to even reply for that.
Okay.
Because let that person go to the court, and the court
and then I will reply. Okay.
And the court won't even send you a notice in that case if it's very non-genuine.
Yeah. If the defense is available, I don't think I need to reply
You don't need to reply to this thing. And
see, many of the times such spurious complaints came. One case, just 3-4 months back, one of the pathologists, where the pregnant patient had come, her HB was shown to be 7 grams %. She had HB done in another hospital where it showed 12 gram %. She delivered, had a normal baby, everything happened. But a notice comes to the pathologist saying that you had given a wrong report because of which I underwent mental agony. So you have to pay such and such an amount. The doctor got so agitated, and wedding was there in her family. She was not able to take part in the wedding party. So she approached me. Then I felt there is no direct damage that has happened. That is what my analysis was. So the hemoglobin report given wrong is maybe the machine was faulty. We do not know. But she has not suffered any damage because of that report. So I asked her not to reply. Afterwards, no court notice also came. So I just wanted a clarification.
Yes, ma'am.
Okay, so this is another thing which I want all of us to know. Medical board versus court. In the medical board, it can be KMC, NMC, or any other state board. So panel of inquiry belongs to the medical fraternity, and it is easy for them to understand the medical vocabulary and make a decision. Whereas in the court, it has to depend on a medical expert for the analysis. So the professional indemnity, last but not the least. So the professional indemnity is one thing which does not save you from the medical negligence, but it definitely help you in the monetary compensation is claimed. So how to choose a professional indemnity? So you should never choose a professional indemnity because some insurance company is giving for a lesser premium. That is not the criteria. Choose an insurance company where the claim rate is very high. Whenever the claim is given, immediately it settles. That is the first criteria. And note that you have multiple claim coverage in a year. And the coverage ratio should be 1:1, not 4:1, 2:1. What do we mean by that? If I have taken a cover for 1 crore, the first claim they will give only 25 lakhs. If the claim is 30 lakhs also, they will give only 25. 5 lakhs has to go my pocket. So I wouldn't want that. So this has to be read in between the lines, understood, and then only the professional indemnity should be taken. And if that company, that insurance company has a provision for out-of-court settlement, how easy or what are the rules of the out-of-court settlement has to be understood. So the provision for an advocate with expertise in dealing with medical issues, is it available from that company also has to be analyzed. Aware of the law of the land. What I understood from studying is it differs from Karnataka to the Kerala to Haryana to some other states. So the person, the advocate who is given by the professional indemnity company should be aware of the law of the land. So anything you want to add, Surya?
So there is one legal maxim which says ignorance of law is not an excuse.
Yes, yes.
So that will have to be borne in mind in this regard.
Okay.
And
so you can't say I didn't know about it.
yes,
You can't claim that. Okay. So now, these are some of the cases which I have chosen. The common negligent acts in anesthesia practice based on the closed claims by various courts. Okay. So 3 ml of spinal anesthetic in a patient with trauma. Okay. And he went into severe hypotension and cardiac arrest. So PAC was not documented and trauma patient, it was not analyzed and 3 ml was given. So it was considered as negligent. So the tonsillectomy related cerebral hypoxia is another case. Probably auto extubation would have happened when they extended the neck. This is what the analysis, but the doctor has been charged. Leaving patient immediately after extubation, this was explained in one of the cases where morphine was given for close reduction and they went and patient had a arrest. So the uncuffed tube in a maxillofacial or ENT surgery leading to aspiration. This is another case. Only after surgeon complained of there is no bleeding in the surgical site, it was realized that the patient had an arrest. This was considered as a res ipsa loquitur. And cerebral hypoxia following general anesthesia, judgment was given based on res ipsa loquitur, which as I have already told you, hypoxia can happen in ASA grade 1 patient without an anesthetist negligence also. This has to be highlighted. So it is usually highlighted that it is always due to the negligence, or it is not so actually. And here where we think it is a negligence, but it was proved to be non-negligent. The spinal anesthesia for hernia surgery was given and patient had paraplegia. But no literature anywhere or no analysis says that following spinal anesthesia, you can have a nerve injuries, but you cannot have a paraplegia. So it was acquitted as no negligence. In another case, post-CABG patient underwent mitral valve replacement and shifted to the recovery room with endotracheal tube for the ventilatory support, and auto extubation happened in front of the anesthetist as well as the surgeon. They were not able to intubate with best of the efforts. Patient succumbed. There also, because of the fantastic documentation, there was no negligence. The steps towards the better legal environment, again, the premium of professional indemnity for anesthesiologist is 3 times that of any other specialist, whereas professional fee is not so. Okay, the compensation calculation, multiple issues we have already discussed. And private practitioners and government employees, both are liable for the medical negligence, even in the consumer protection court also, because both of them are giving the paid services. At this point of time, I also would like to say whether the anesthetist is employed by the surgeon or it is employed by the hospital, he is made liable because he is paid for his service. So the steps that can promote safe practice, medico-legal closed claims should be available. You need not mention the patient's name, you need not mention the hospital name, but whatever the facts of the case, so that we are aware how the patients are thinking about the medical fraternity. And with social media being so extensively available, people are thinking in all kinds. So we should know what is happening in day to day, not just what happened a decade back. Postgraduate teaching and exams should include topics on medical negligence, and they should be given about 20 to 30 marks questions. If the questions are not given, the postgraduates are not going to read about the medical negligence. A case filed at a lower court reaching to the Supreme Court, as we have seen, it takes a decade or 2 decades many of the times. So when we have a real defense, is it possible to go through a expert panel opinion? If the expert panel decides that there is no defense, can only that be go to the court? Otherwise, can it be avoided by going to the court? These are the things which our authorities have to discuss with higher authorities and come to a conclusion. So the things to ponder upon, doctors are soft targets. Even one legal notice, we start shaking. So we are not used to it. Okay, any notice from the court will disturb the practice and privacy, as well as we are not taught to observe that legal notice can be a part of our profession. Professional indemnity should be popularized, though the cover U is nowadays doing it. It should be popularized even among the postgraduate students. So how to reduce liability? Communication. So we think surgeon has communicated, we need not communicate to the patient. The communication is very, very important. In many of the times, many of the claims, it has been told that the doctor even refused to speak to us. He refused to come and see the patient. We wanted to punish him. That is why we put a case. So it is possible even after a complication. If a complication happens, go and talk to them and explain to them. Don't run away from the situation. And the expectation is reasonable skill only. Don't think that, oh, I don't know that, I don't know this. Any reasonable anesthesiologist, whatever skill has, that much skill only is required. Documentation and communication of the documentation, which we have discussed elaborately. Avoid rude behavior, even if the family or the patient's relatives are behaving rude, because their loved one is in danger or has died, so they will be behaving rude. Let us behave professionally only. This will reduce to a great extent the liabilities. Okay, this I think all those who are live in this webinar, please read this. And if internally, if you are thinking, I have understood absolutely nothing, that is why I have no doubts. There are 3 doubts in the chat box. So I think somebody has understood something. Thank you. Can we go ahead with the chats? The questions?
Yes, ma'am, please.
Okay.
Go with questions. You can
Okay.
have in chat.
Pardon, sir?
Hello.
Hello.
Yes, ma'am. Sir said proceed with the chat.
Okay,
Question
sir.
in chat.
Okay, thank you. So the first question is, ma'am, a patient with PPH under anesthesia, should we need the patient consent for hysterectomy, or if husband consent is enough? We have already explained. Yeah, you would like to talk,
Yes,
Bhargavi?
yes.
Yes, very good. Very good. Yeah.
So there is this case that I discussed about Arjun Balakrishnan Iyer versus Sony Hospital, where the patient was posted for ovarian cystectomy. And during the procedure, the uterus started bleeding profusely, and the surgeon went out and took the consent of the husband and proceeded with hysterectomy. The patient, after waking up, filed a complaint against the Sony Hospital and the doctor involved. But the doctor and the hospital both were acquitted because this was done to save the life of a patient. So even under anesthesia, we can continue to do the procedure only if it is a life-saving procedure. But as an anesthesiologist, it is our duty to go out and take a consent for continuation of anesthesia for the said procedure. This is very important.
So the PPH, okay, the PPH has various types of the treatment. Okay, the artery supplying the uterus can be thrombosed. That way also you can save the uterus. Okay, so it depends on the situation. But for the hysterectomy, if there is no other thing available to save the patient, the husband consent is enough. If that is not so, you cannot go ahead with the hysterectomy. Dental damage during intubation when done by postgraduates, what is the actual procedure to avoid. So then dental damage is a very big thing actually nowadays, because the dental treatment is very expensive. So, and also not only that, as per the criminal law, dental damage is considered as a grievous injury. So always dental damage should be avoided. And if it has become from your postgraduate, you are only responsible for it. And if it has not entered into the trachea, at least there is some relief. You can talk to the patient and you can provide him with the dental treatment amount. Or if you previously, when you are doing a pre-anesthetic checkup only, if you can say that dental damage is possible, that should be explained to them and consent should be taken. Many of the times we do this also when we perceive difficult intubation, buck teeth, and there is something called as the dental protectors. But when you use that and intubate, the space in the mouth decreases very drastically, and sometimes it makes the intubation more difficult. Yeah. So the laryngospasm can happen in any pediatric cases. Should we get a consent for this from the parents for all pediatric patients? See, that is what I said about the transparency versus diplomacy. Okay, so children are prone for this kind of things. It can happen once in a way. We don't know whether the incidence is possible or not. It has to be explained. The pediatric patient is not equal to an adult patient, and they have unique problems which are attached to the pediatric age group as such. This has to be explained and diplomatically managed.
Ma'am, can I add a sentence here, ma'am?
Yeah, please. Please.
Ma'am, any complication which the chances are more than 10%, it has to be mentioned in the consent form, and the consent has to be taken for the same. So
Yes.
if it is less than 10%, I think it can be avoided. It can be told that this chances is, that's what you need to tell them how much is the chances which can happen, and you'll have to get it documented.
Okay. I don't know. I'm not able to scroll down further. There are more. Over or more, I think 3 only were there, na?
Only 3 were there.
Yes, ma'am. Only 3 questions were there.
Okay. Okay, we have answered all the 3. Any more, you can post it. We will answer.
Thank you.
Receipt, ma'am.
Yeah. Hello, I am Radhakrishnan. I want to know something more about this 10%. Prashanth, could you explain more in detail about this 10%?
Prashanth.
This 10% business.
Yes, sir. Sir, whatever we take the consent, sir, if you expect that the complications are more chances of happening, so this complications, how frequently it can happen? Out of 100 patients, if you feel 10 patients can have this, yes, that has to be documented in your consent form. And you should mention that these are the complications because of this procedure. It has to be documented and has to be taken. Lesser.
The issue is that 10% comes from which statistics? That becomes a major issue. See, for many things, we don't have statistics of India available to us at all.
We don't have any statistics also today.
Yes.
But this 10%, I don't think it will take us anywhere. Because complication, we represent or we rather document all the complications possible. All possible to our mind. But there may be occasional complication which we have not anticipated even occurring. But this 10% compensation, I really wonder, what do you mean, Prashanth?
Maybe if you have a national guidelines which are explaining for all the complications, anesthetic complications like that, it may be. But we don't have statistics for many things. As I told you, medico-legal closed claim statistics only is not available to us.
Yeah, correct. Yeah, we don't have any closed claim statistics. Another thing, because Surya, I'm sorry, I was not able to introduce you in the beginning. I was not sure whether you are joining.
No issue, sir. I'm very glad to be here. There's so much enrichment of knowledge.
Yeah. Thank you very much for joining us. I'm sorry I was not able to introduce in the beginning. Okay. So the only
Likewise, sir.
And we have one more question.
Now, one thing more, Surya, you were telling about this particular from the National Consumer Forum. You may not be able to withdraw a case for out of court settlement. Is that so?
So you can't. You can always convince the person for an out of court settlement and file a petition there. But you can't convince the court, the forum, to direct you to go for mediation. Say sometimes what happens in civil courts, two people have a case. Court feels that it can always, this case need not go further. They both can settle among themselves.
But
So
will
court,
consumer forum anytime, anywhere request you to go for an out of court settlement?
consumer court itself doesn't have power to direct for arbitration.
That's what I was believing. If
Yes,
individual wants, they can go for an out of court settlement and then give a joint statement that we are interested in going for a
Yes,
out of court settlement.
correct.
That is possible anywhere in the district court or state court or in a national forum.
Correct. Yes, if parties consent for it, they can. But if the court cannot do it by itself. Court cannot do it by on its own volition.
Court cannot do it.
But in civil cases, it can.
Yeah, civil case, I agree. Civil case, it can.
Yes.
The other thing, what I heard in between, the iatrogenic complication. Iatrogenic complication, does it carry any compensation? Because the iatrogenic complication, all of a sudden it happens because you are not in the knowledge of those things. It just happened. You are bad, like it happened. Well, it is going to be dealt like any other complications. Because iatrogenic complication is not at all going to get any relief as far as I know.
No, sir. Iatrogenic complication has to be proved as to be iatrogenic.
Correct.
Right? The term per se does not carry the message.
But even if it is proved as iatrogenic, well, will that carry any meaning? You mean if the court wants, they may be able to subside it down, is it?
Sir, ma'am, can I please take this?
Yeah, please.
Sir, in case the patient is able to prove, because the burden of proof is on the patient, in case the patient is able to prove that it is an iatrogenic complication, now the burden of proof shifts to the doctor, I suppose. So he has to now prove that this happened as per the course of treatment, and this could happen with anybody else doing the same procedure.
Yes.
So I think if he is able to prove that he's not committed the error because of which the negligence and the damage has happened, then maybe he can maybe he could be acquitted.
Proving something as an iatrogenic is not resting with a patient, it's resting with a particular operator or the practitioner. If I make a mistake or if I prove that this thing happened as iatrogenic, well, I have to prove, not my patient who is the sufferer.
So the who has claimed is patient only, no, sir. I don't go and claim that I did iatrogenic, na?
Yeah.
Sir, may I just add one thing, that proving something as iatrogenic is not same as proving something as negligent.
No. Yes.
And again, the negligence these days, that time-old definition is by an act of commission or an act of omission. Well, nobody commits a negligence as an act of commission. Do anybody do? I don't think so. It always happens, or most of the time it happens as a matter of omission. Am I correct?
No, sir. If you give 3 ml of a local anesthetic to a hypotensive patient, it is commission only.
Madam, if it is a very low dilute, I mean very, it's what percentage of this particular solution counts? If it is something like 0.25% or 0.125%.
Yeah, it is very less, no doubt about it.
Yeah. It depends on, well, if you are correct in the sense that if you're going to give a high concentration, local anesthetic, which is not warranted, well, that is going to be a commission, I agree. But otherwise, if it's a low concentration drug high volume is not going to matter much. Well, one may be able to prove I may have to give more volume to fill a particular space for the desired effect. Well, you may be able to escape that particular way.
Yes, sir. That is called as the explanation, and sometimes even contributory negligence will come as defense. I have not spoken extensively about the defense actually.
Yeah. And I was thinking about that. That's why I said that.
Yes, sir.
Okay.
We have one more question, ma'am, regarding awareness of anesthesia.
Can you post it?
Yeah, it is already there in chat box, ma'am. Awareness under anesthesia. Yes.
Okay. Chat
Ma'am, it says,
box shows nil, yeah.
Ma'am, it says awareness and anesthesia. Ma'am, how to substantiate when we don't monitor BIS for all cases?
Repeat the question.
Ma'am, it says how awareness under anesthesia. Ma'am, how do you substantiate? Like there is awareness anesthesia when we don't monitor BIS for all cases.
Yeah. Anybody is answering?
Ma'am, can I put my view in this, ma'am?
Yeah, put it. Yeah, please.
Right now, there's nothing like we have any previous court cases or something, or no kind of a law in India as such, where awareness under anesthesia has been taken to the court as of now.
I don't think so. We may not be aware of it, is what I think.
But in the Western world, yes, it has been taken to the court. And if a patient was having awareness during anesthesia, yes, the doctor has been proved as negligent anesthesiologist and has been sued. So in India,
so my version is anything else to be spoken, you complete.
That's which I am aware of.
Okay, so now my version is, if you don't have a BIS monitor, you have a MAC available to you. So throughout the procedure, MAC is displayed over there, and along with the MAC, you would have given IV anesthetics and you have maintained the hemodynamics. These are the things which we monitor in the absence of BIS. That could form a very good defense.
Well, awareness under anesthesia, if something really bad, well, the whole fault of that falls on the anesthetic.
Yes, sir.
The whole fault, because nobody else could be made responsible for that. Fortunately, the litigants are less in India, but in India also, many times such a question has come up, compensation award. But it's almost common in the Western country. I mean, the Western Europe, as well as in States or Canada, well, these particular areas. Well, there, if you say that you are under knowledge of what is going on around, well, with multiple questions, they may be able to prove was it correct statement or no. If it is correct statement, a proper investigation is done, and if proved correct, well, anesthesiologists unfortunately may have to pay large amounts as compensation, because that is going to destabilize the individual's mind and the future, and many things are connected to that. Anyway, luckily for us, not many things are happening, or rather, we don't have any standard format in this particular country.
Yes, sir. National guidelines for these things, if it is made available, that can be used as a defense.
It's not available now, madam.
Yeah, not available now. Yes.
That way we escape. That's all. But occasionally case comes in.
Yes.
Any more questions?
No more questions.
Okay.
So, thank you, Dr. Sunitha.
Thank you, sir. Thank you for the opportunity.
And your team members.
Thank you so much, sir.
Surya,
So much.
Thank you so much, sir.
for the excellent comprehensive description on all the medical and legal matters and how we could proceed.
Thank you.
Certain things we have not touched on today because death on table or how far a vicarious claim falls on the supervisor when a postgraduate is doing something. This particular issue, this issue is really large because we don't have any particular written down consensus on this matter. And these sort of things and other left out areas. And again, how to notify a death, how to write a medical legal certification.
Yes.
Basically, how to make a death certificate declaration.
Death certificate, yes.
Yeah, these sort of things. It has to be discussed at length. Hope we may be able to do in another 3 months' time. Probably next session of ours will be on these areas. Okay.
Okay,
And
sir.
thank you very much, Dr.
Thank you,
Bhargavi,
sir.
Prashanth,
Thank
Madam,
you, sir.
Thank you, sir.
and Mr. Surya.
Thank you,
for
sir.
being and doing this particular webinar. Such a wonderful event. Thank you. Thank you once again. Wish you all the best.
Thank you, sir.
Thanks to all the panelists.
Thank you.
And I'm extremely happy.
Thank you all. Thank you.
Thank
And
you.
it was a very enriching session.
Thanks.
Thank you, Claire,
Thank you so much, sir.
for being with us.
Thank you.
Good
Thank
night
you.
to all. Thank you. Yeah.
Good night, sir. Good night to all.
Yeah. Thank you.
Thank you, one and all. Thank you.